So thanks very much for the invite back. It's great to be here. I had a fantastic year last year. This is one, I had lots of opportunities to get into various different projects. This is one of the main projects that we were involved in. So it was setting up an in situ simulation scheme on the acute medical unit. So some of you may not know what in situ sim is. So this is carrying out simulation scenarios in the workplace, on the ward, with clinical staff who are doing their normal activities. So it's not like normal simulation where you may take people away from their workplace to a sim centre and they have a day off work. This is on-the-job training. And the benefits of this is that it's quick to set up, so you can instigate training in the midst of the working day, and you can involve teams and get them training together just as they work together. And the reason we did this was because we'd had some feedback from a cohort of medical registrars, some of the senior medical trainees who work in hospital, about the challenges of getting to training, about the type of training they were receiving. And this was echoed by a report in the Royal College of Physicians, which also highlighted some needs for changes to the training of the medical registrars, particularly about how training should be dealt with in terms of leadership skills. With increasing consultant-led service, senior trainees are having a bit more difficulty getting opportunities to have feedback on their making decisions and leading teams. So the aim of the project was to deliver a weekly in situ sim session on the acute care unit aimed at the on-call medical registrar leading their multi-professional team. And we use this piece of kit, which is called an iSim. It's from an Australian company called iSimulate. And essentially it's two Apple iPads, which are remotely linked via a wireless connector. And the one in the yellow case acts as the observation machine at the head of the bed. And then the facilitator would use the other iPad to basically change the observations. And that would act as the center point of the scenario. And we couple that with a resus Annie mannequin, and then we could run scenarios which we'd normally run here in the education centre on the wards in the hospital. So we undertook the project on the acute care unit. This is a 35-bedded unit, has 600 to 700 admissions a month of medical and surgical patients. There's about 10 junior staff that work on the unit, doctors, and then about 13 nurses. And we decided to run the project for a 6-month period between November and May 2014. So before we started, we wanted to get some input from our stakeholders, people who are going to be involved in it. So these are our junior doctors. We spoke to them and to find out what they needed, what kind of learning needs they had. Was there anything in particular that they wanted us to focus on? Did they have any other training sessions through the week that we wanted to avoid, we didn't want to clash with? We spoke to our consultants. They were keen that this was a multidisciplinary training, but also that it didn't impact on the work that was going on in the ACU. It was a busy unit. We spoke to our nurses, very important. They were our patient advocates. They made decisions about what time of day we could be running these sessions. We didn't want to be interrupting meal breaks, rest times, drug rounds. And we spoke to our managers just to be sure that we weren't upsetting anyone by running training on the wards in clinical areas. We also spoke to the patients, because this would be the first time that we'd be running training in front of patients, in front of the public, and to get an idea of what their perceptions of it would be. And we created a kind of consent form, information leaflet that they could take and understand what we were doing, so they weren't upset or disturbed by it. We had this translated in various languages just to reflect the diverse population in Hackney. We wrote a number of scenarios. These were based on clinical incidents that happened in and around the Homerton Hospital and were mapped to the general medical curriculum. So we had a patient that had been repatriated from the hyperacute stroke unit who presented with overwhelming sepsis. We had a gentleman who presented with encephalopathy and an occult GI bleed. Someone who we thought would be having a diabetic ketoacidosis, but actually was having a tricyclic overdose, a new diagnosis of HIV, someone in respiratory failure, and complications from oversedation. And these are all quite challenging cases. They're aimed at the senior trainee, and it basically challenged them to lead the team and use all their available resources. So we wanted to keep the scenarios short so they didn't impact on the working day. So the way they set up, the way we worked it out was that we'd have a 10-minute setup. We'd come down, the faculty would come down onto the acute care unit. We'd try and find and allocate a team, contact the on-call registrar. We had someone who'd cover their on-call bleep. We'd consent the patients in the room, in the bays, to make sure they understood what was going on. And we set up the mannequin and the iSim. We then only ran the scenario, actually ran for just 20 minutes, and that involved a nurse to medic's handover, and it involved the nurse in that bay and the FY1 or FY2 in that bay as well. So tried to involve not just the medical registrar, but the whole team. And then we went away to a quiet room just around the corner from the ACU where we could sit down, go through what happened, what could have been done differently, review all the learning points, and also identify, was there anything that occurred in the system on ACU that we could have improved to avoid any problems occurring in the future. And then we collected anonymized paper-based feedback from the participants and from the patients. We tidied up all the mess we created during the 20-minute scenario, and actually we offered a mini KEX, an assessment for the leader of the team, so they had something that could go back, something formal feedback they could go back into their portfolio. So I've got a quick video just to give you a taster of what these scenarios were like. So I'm sure you're keen to hear the results of what we found. So we delivered 24 sessions over a 6-month period. Only on 2 occasions were we not able to run the sessions because of either lack of beds or lack of staff. 5 simulation faculty were involved. That involved a couple of fellows, a consultant, a nurse specialist, and actually an F2 who was involved and interested in sim training as well. 11 registrars received training out of 14 that were on the rota, and I think if we continued the training through the year as we have done after the study, we would involve all the registrars. 2/3 of the scenarios were led by a senior trainee. On certain occasions, the trainee was busy at an arrest call or an emergency, wasn't able to attend. It was voluntary. Some registrars weren't keen on being involved. But this gave opportunities for other more junior members of the team to act up and try and run a scenario and get some feedback on that. So 100% of the health professionals feeding back to us thought that this was clinically relevant to their training. They all thought it was beneficial to train in their usual working environment. The vast majority felt it was beneficial to be working and training in a multidisciplinary team, and less than 10% felt it was disruptive to their normal workday activities that day. Some of the feedback that we got from the doctors and nurses, that it would help improve their practice in the future, that it was good to see how other members of the team would manage these emergencies, running the simulations on the ward, making it more realistic. Nurses who complete this training feel more empowered and improve multidisciplinary working. We also got feedback from the 28 patients and visitors. Over half actually already thought that this was how doctors trained already, which I thought was interesting. They were all reassured that doctors and nurses were receiving this training on the days that they were being looked after by them. Some of the patients thought that it would give confidence in the doctors and nurses' abilities. It may be confusing for some patients, and we should take that on board. It was good to see that patients could see doctors learning in front of them. That the doctors showed that they were composed and showed they care, and actually it was a good break for the day. It was something to take away from the mundane life on the ward. So we've seen this slide a number of times, but one of the aspects that I hadn't anticipated was because we were running these scenarios on the ward with doctors and nurses, we were picking up potential errors. We were picking up latent areas where we might identify something that might have gone wrong that we could rectify, the sort of holes in the cheese. And so we discussed these in the debriefs afterwards, but it was very important we had some robust way of reporting it so that we didn't make the same mistake again, or it didn't actually happen in real life, but also that other wards and other areas of the hospital could learn. And so we managed to discuss with the Patient Safety Committee in the hospital, and they agreed that every time we found a latent error that we should actually report it as if it was a clinical incident, as if it was an error that had occurred. And these are some of the areas that we found. They tend to be lack of equipment or lack of knowledge about protocols, and we managed to come up with solutions to all of these. So there's a few things that I wanted to draw from this, particularly thinking about the theme of this conference. That this is when I started this project, there was a number of perceived barriers that we had. We thought that this was the busiest ward in the hospital, that we were involving the medical registrar. How on earth are they going to be able to save 40 minutes to do some training? But actually, we found that there was always a response of yes, we can do this. And whenever we went to and speak to the committees to get money for funding, they said yes. And speaking to the nurses in the ward about beds, there was always a yes, can-do attitude. So because it was very feasible, we managed to actually move this project to other areas of the hospital. This is a photo from us doing it in theatres, and we've done it on radiology. And actually, when you're on an acute medical unit, you should expect them to be able to manage acute medical emergencies. But going to places where maybe they don't see these aspects as frequently, you can see the benefits even more. So doing it in places like radiology, where maybe they may be seeing some of the sickest patients